Welcome back to the American College of Surgeons Bulletin Brief from the Frontline Surgeons' Voices. With me today are three surgeons who have been through site surveys by the American College of Surgeons Commission on Cancer National Accreditation Program for Rectal Cancer, all three of whom have gone on to become site surveyors on behalf of the NAPRC. With me are Drs. Shankar Raman from Des Moines, Iowa, Jan Kamiński from Chicago, Illinois, and Ted Voloyiannis from Houston, Texas. Let me ask you first just to describe a little bit of your hospital background. And the reason I say so is in 2011, when the concept of the NAPRC began at the inception of the precursor group to the NAPRC, we aimed to improve rectal cancer outcomes for patients throughout the country, which meant being inclusive and having all different types of hospitals, different sizes, different structures, different models of medicine being practiced in them, full-time staff, private, academic, non-teaching, to include everybody. So if you could just give us a little thumbnail on the type of place in which you work.
MercyOne Des Moines Medical Center is a 650 plus bed hospital. It's a community hospital. The serves a population catchment area of about 600,000. It's a level 2 trauma center, and there are training programs in general surgery, family medicine, internal medicine, psychiatry, and a fellowship in cardiology. Ours is not a big rectal center in regards to volume. We see probably between 30 to 40 patients a year. It varies. Probably with the pandemic, we saw somewhat less than what we typically do. But that's how our practice model is. We do have a mix of surgeons and others in the MDT who are employed and who are in private practice. So we have people with great working relationship, but not the same employment model.
I work at Illinois Masonic Medical Center. It's located in Chicago in the downtown area. It's about 300 to 400 bed hospital. It also has a general surgery program. It's a level 1 trauma center. It's a community hospital that that focuses on the community in the area in Chicago.
I work in Houston, where it's we're very close to the largest medical center in the country, essentially. However, my hospital is also a community hospital, 462 beds. We're also level 2 trauma center. We do have all the service lines, including neurosurgery, cardiothoracic surgery, and colorectal surgery and general surgery. It does have employed general surgeons. I was initially the only colorectal surgeon. Now we have one more. And it serves the community of south of Houston, which is essentially more than 1 million. However, the hospital is close to multiple academic hospitals affiliated with academic institutions that are satellite hospitals in the area.
So let me leave you with the microphone and follow on and say, number one, why did you decide to pursue NAPRC accreditation? And number two, what are some of the steps you had to go through to convince your administration and others to follow through with you on requesting accreditation?
The concern I had since I started practice here in Houston 15 years ago is that the care in terms of the rectal cancer, as well know, requires a multidisciplinary team approach. However, it is very fragmented in the community setting. We have the general surgeons, the oncologists, the radiation oncologists, gastroenterologists, and so forth. They're all working different private practices, and sometimes the communication is not good. Patients end up going from a physician to physician. They get lost in the system. There was delaying care. Sometimes the standards are not applied, and patients' oncological outcomes may not be optimal, even though for the hospital requirements may meet their criteria for surgical outcomes, for example, surgical site infections and so forth. So that bothered me because I always struggled to get a patient with rectal cancer and offer him end-to-end care when I was the only colorectal surgeon here in the area, the community hospital. So pursuing the accreditation was not easy because primarily I had to persuade not just the administration, but also all those physicians that I've been working with all these years to get together, and sometimes they're working for competing groups or practicing in multiple other hospitals to get together and develop the center. In terms of the administration, sometimes this is not as easy as we think, because administrations in hospitals are many of them are very interesting to pursue accreditation for breast, for trauma, bariatrics, all that. And then rectal cancer, that doesn't sound very fancy sometimes, but after understanding the importance of that and developing a local cancer center here, they were fully supported and they helped me do it.
Dr. Kamiński, so let's shift north up to Chicago. And you managed to get your program approved. What was the length of time from when you said, I'd like to have my center NAPRC accredited until you actually had that certificate of accreditation?
It probably took at least 2 years for the full process for me, from the inception of the idea to accreditation. Just like Dr. Voloyiannis mentioned, you have to get all the key stakeholders involved, including administration, and also all of the physicians that are involved, including pathology, radiology, surgeons, radiation, and medical oncology. We had to get them involved on a personal basis. So I went along and talked to each and every one of them and discussed with them why we need this program. And why do we need it? It's kind of like Dr. Voloyiannis mentioned, the outcomes are much better. I live in a metropolitan city in Chicago, and the standards just between different hospitals in the city can be completely different, which means that the outcomes for these patients can be different and a lot of times suboptimal. So that was kind of the reasoning that I discussed with all of the key stakeholders. And from that point on, then we had to take about another 12 months to make sure that all of our standards are actually being met before we were able to apply for the accreditation. And after the accreditation, usually you have some areas for improvement, and that can take another 6 months. So total, at least 24 months, but we were able to do it within that time frame.
Now, we've heard about outcomes a couple of times, and we've also heard about the team and you need people in various disciplines. But Dr. Raman, did you have to incrementally add any people in order to fill the requirements for accreditation, or did you have to just bring pre-existing people together?
We did add a coordinator for the rectal cancer program. That was the only addition in personnel that we made. And that was possible because we were going through some changes with our general surgery residency accreditation, with challenges in our accreditation that has since then been rectified and addressed. So we did have a coordinator who started then. But as Dr. Kamiński and Dr. Voloyiannis said, we needed buy-in from all the physician groups. And how we got support was we made sure that the physicians were on board first before we reached out to administration. And once we had multiple physician voices advocating for the same progress, it was easy to get administration to move in the same direction.
Great. And while you have the microphone, have you noted any change in your patient outcomes since you began seeking accreditation?
I would say that the process is very standardized. Everyone knows what these patients have to go through. Even if it is a private practice medical oncologist, understands that patients have to be discussed at the NAPRC MDT before the definitive treatment starts. So there is complete buy-in from various stakeholders in this process. And patients also know that they are getting evidence-based guideline-supported treatment. So there is more uniformity and less chance for confusion. And overall, the sense of knowing that we are an accredited rectal cancer center and that we follow evidence-based guidelines has promoted how we deliver rectal cancer care.
That's great. So people know what you're doing. People inside know the people outside. Dr. Kamiński, what's been the response of your patient population, your patients with rectal cancer, as well as referring physicians?
Once we develop the accreditation, the next step is to let everybody know that we actually have the accreditation, that all the standards are being met, that all of these patients are actually being seen as a multidisciplinary group. The response has been very favorable from all parties, including the administration, the physicians, especially the patients. With the coordinator, the patients really get to have that personal experience and there's much more streamline and efficiency in the care that they receive. So I feel like all of the key stakeholders were very satisfied afterwards.
Great. Dr. Voloyiannis, not only did you shepherd your institution through a successful accreditation, but then you went on to become a very active participant, as all three of you did, and I personally appreciate it, to become a surveyor. What does it mean to be a surveyor? Not everybody may understand what your responsibilities are in that role and your time commitment.
Well, initially it was a challenging task. It was something new for me as well. While I was setting my program in order and making sure that we're meeting the standards every day, and through all the internal audits, finally, I understood and I mastered on how to keep my program on check every day. Then moving forward, I understood all the processes needed to be put together between hospital administration, clinical staff, physicians, ancillary staff, and even the office staff of the participating physicians. And then becoming a surveyor, I felt that I was ready to not only check on those programs if they actually meet those standards, but actually also help them and guide them to meet the standards and become a successful program as well. So my desire is actually to help them meet the accreditation, because this way they can help their local patients, their communities. And also the other reason why I become a surveyor is every day I still learn from other systems and facilities that I visit. And believe it or not, every time we learn as surveyors something new that they do and help us implement it, and not only in our programs, but also help the NAPRC to get better.
Fantastic. Dr. Kamiński, we all think of site surveys in terms of somebody showing up, whether from JACO or ACGME or the Residency Review Committee or COC or NAPRC. The COVID pandemic changed the way visits were conducted. And could you describe for us a little bit about some of those changes?
Sure. So initially, just kind of like you mentioned, the site reviewer process means that the site reviewer, the actual person, goes to the hospital, meets everybody in person, discusses the program, discusses the positives and negatives of the program, and then reviews all the standards. And that's usually that happened in person. Because of the whole COVID pandemic, that completely changed the entire process. What does that mean? That means that everything happens now virtually, meaning through some sort of platform like Zoom or Microsoft Teams. We still meet all the key stakeholders. We still have all of the meetings that we had in person before, but now it's virtually. So it is a little bit different. There's positives and negatives to this, but we can still do everything that we need to do through a virtual setting. And I feel like we can do it in a competent and efficient way.
Dr. Raman, if somebody is interested in becoming accredited, they can obviously read on the NAPRC website, within the ACS website, what's required. They can put things together. But are there other educational resources which people can avail themselves to learn more about the process? Some tools may be available to them.
I think the Commission on Cancer and the American College of Surgeons, along with the American Society of Colorectal Surgeons, have put out webinars teaching or educating people through the process. The Educational Committee of the NAPRC is spearheading those efforts of how to disseminate the information out to those programs who are interested in this. And those, I think, are the avenues that interested programs can tap into.
Thank you very much. We've covered a lot of ground. You've all performed very admirably as site reviewers, and very commendably, you've gotten your programs accredited. And your presence here today and your enthusiasm and your support for the program is attestation that our original aim of improving outcomes throughout the country is being achieved at a variety of hospital settings and many different geographic locations. So kudos to you, thanks to you for what you do for the program, and thanks for your time today.
Thank you, Dr. Weston.
Thank you.